Thanks for joining me for part 2 of your schizophrenia lecture. This section is going to focus on how we care for clients who have a diagnosis of schizophrenia, specifically addressing the psychosis. We want to understand and implement an evaluation of psychotherapeutic drugs used to treat people with schizophrenia and their impact on the nursing care, planning, and intervening. We want to be able to formulate nursing diagnosis based on what we know about the client, and we want to think about recovery-oriented nursing interventions. So in this section of this lecture, we're going to look at the medications we give them, the risks associated with those medications, how we assess our clients and evaluate them for side effects as well as efficacy, and then how we formulate a nursing diagnosis related to what's going on with them so that we can really coordinate their care well. In the slide in part 1, the last slide, I really focused on the importance of an interdisciplinary treatment approach. We want the whole treatment team to come together and help address the concerns with the client and work together. This section is going to focus on the nursing perspective of it. What we know for sure with schizophrenic, with clients who have schizophrenia, is the biological domain is the one we hit the hardest. It's because we know that schizophrenia is a biological disorder. It is all about the dopamine pathways, how they're being altered in this disease process. So how we handle the biologic domain is huge. It's also why so much time, energy, and money has gone into doing the research related to pharmaceutical interventions for clients with schizophrenia. The biological assessment, when we look at when we assess information for our clients who are presenting with positive, negative symptoms as well as neurocognitive changes, we're going to be doing a really good current and past health history and a good physical exam. We do not want to assume during that first phase of diagnosis that because they have alterations in their perceptions that it is immediately schizophrenia. I have a very personal experience in this, in that my younger brother, when he was about 18 or 19, began to, he shared with my mom that he felt like he was seeing things. He'd had some intermittent depression, but nothing major, and all of a sudden he began to see things. And over the course of about 2 years, the visual disturbances changed. He would say things looked like they were floating in front of him, that things were moving that weren't really moving, and they began to treat him with antipsychotic medications. He was in and out of a mental health hospital probably 3 or 4 times, primarily for medication adjustments because they were trying to get the visual disturbances to stop. As they were treating this, he was finishing up his senior year in high school, began to get more and more depressed because things were not going well. So it became this vicious cycle of the depression worsened because he was being treated for these visual disturbances that they thought were psychotic features, and it just began to escalate. Well, he was not quite, I think he might have just turned 20, woke up one morning and was almost completely blind. And of course, that doesn't happen to someone who's had 20/20 vision. He was rushed to the Medical College of Virginia, admitted into their ICU setting, and they found that what he had for the past 2 years was actually optic neuritis, which was his first sign of his early diagnosis of multiple sclerosis. So he didn't have psychotic features at all. No one did an MRI. No one looked at, the other medical things that were going on. They just assumed that because he had a history of depression that he began to have psychotic features, and he was in that perfect window of developing schizophrenia, and they were just certain that that's what it was, and that wasn't the case at all. So he was admitted to MCV. They put him on IV steroids to get the optic neuritis under control, and was very quickly diagnosed with relapsing and remitting multiple sclerosis. He was not even 21, and they missed it. And for 2 years, he was treated for something that was not actually the diagnosis. And that really came from assumptions being made by the medical community. And of course, when your parents and your kid says, they're seeing things, you panic. No one stopped and did a good health history, and no one thought, let's make sure this isn't something else from the medical world. So when we think about a biological assessment for someone who's having alterations in their perception, it is so important that we do a good health history, that we find out what their health histories look like, and that we do a really good physical assessment. There were early signs for my brother's case that were just missed because people didn't do what they should do. I guess he's 42, 43. He just had a birthday. And he's been living with MS for 25 years. So this was a real tough lesson for our family in understanding what it meant to get good medical clearance before you put your toes in the mental health world. When we look at the biological assessment, again, you want that health history. You also want to make sure you know all their medications that they're on, and you need a good history on any illegal drugs they're using, because some psychotic features can be brought on through drug use, so we want a good drug history. A good provider is probably going to request a urine drug screen just to verify what they're being told before they get too far down the bunny trail. From a nursing diagnosis standpoint, from the biological domain, we're talking about basic function. And with basic function in the biological domain, you're talking about basic self-care. So we look at self-care deficit, and that's related to the avolition that you see with clients who are dealing with schizophrenia. They stop self-care. They stop bathing. They stop hygiene. They stop house cleaning. They stop eating well. Everything goes sideways from a biological standpoint. They stop taking care of themselves. So the self-care deficit is a real issue. When we think about interventions, we are going to really focus on helping medication management, making sure that they are getting as much health teaching as they can related to their medications. And we're going to make sure that we are really promoting and encouraging activities of daily living, that we help them get back on track in regular bathing and shaving and clean clothes, the things that the negative symptoms have robbed them of. We're going to help them get back on the bike and get that oriented. I want you to be aware that the discus is out here, as well as the AIMS scale. You don't have to memorize these. I put these up here just so you could see kind of the questions they're looking for. The other thing from a biological domain we're going to be assessing is we're going to be looking for abnormal movements, and this is especially important after a patient has started a psychiatric or psychotropic medication. So the discus and the AIMS scales help us get an objective measurement of abnormal movements that are a real risk for clients who have psychotropic medications or the antipsychotic class on board. So this is the example of the discus, and the next slide is the abnormal involuntary movement scale, and this is called the AIMS scale. You're going to see these loaded into the electronic medical record, especially in acute psych. And you're gonna the physicians are often going to be the ones that are going to be evaluating this, especially if there's a new psychiatric drug on board. So I do want you to know that these two scales are out there, and that it's there to assess people that are using the antipsychotic medications. Okay, so let's talk about antipsychotic medications. The primary purpose in antipsychotic medications is the blockage of the dopamine transmission. And keep in mind that dopamine works in 4 neural pathways. You don't have to remember those pathways. I just want you to know that one of the complexities to antipsychotic medications, because there are 4 pathways in which your body tracks dopamine and where the receptors are, it can be extremely challenging to find the right combination of antipsychotic medications that would be effective for your client. So we're going to give it 1 to 2 weeks to see if there's an improvement in their symptoms. Normal trials last at least a couple of months, normally 2 to 3 months before there's a change, because you have to give your body time to adjust. Then you've got to treat any side effects from the medication. So it takes some time to shake all of this out. All the while, the patient may be dealing with acute symptoms. So this can be really, really challenging if you've got someone that's acutely psychotic and believes that bad things are happening to them, and they're mistrusting because of their psychosis, and you keep trying to give them medications. They may not trust you, so compliance becomes a real issue. So developing trust with these clients is super, super important, because they have to know that you're going to first keep them safe, that you're going to be with them, and that the medications that you're trying to get them to take, that you're going to be consistent with them in administering it and making sure that they are okay while they're taking it, and that they trust you to not be trying to harm them. We are going to be really watching for side effects for medications. A lot of the medications are super effective, but they also have super scary side effects. One of the ones that is on this slide is the clozapine. I would just want to point that out, and that's going to be one of the drugs we're going to pull out and talk a little bit about, because it's highly effective, but it is super scary. Lots of side effects. So I do want you to know that it's in our second generation list, but it's one that's only used when we really can't find something better to use. We're going to talk about extrapyramidal side effects in just a moment. So when we think about the antipsychotic medications, I want you to be thinking about them in two major groupings and then one minor. So we have first generation antipsychotics, and then we have a second generation group of antipsychotics. And then there's a third generation, which is the Abilify drug, and that was really on the very tail end of the second generation. It had some improvements that were unique to that specific drug, which is why they started a third classification. If we go back to looking at the first generation of antipsychotic medications, these medications were beginning in their development in the 50s and 60s. They were specifically targeted to work on the disruptive symptoms that were seen in psychotic patients. The behaviors that made them dangerous and unpredictable and difficult to assimilate into society. So they were targeting the positive symptoms, the patients that were actively hallucinating or had active delusions that made them aggressive or dangerous to other people. They were highly effective, but they also had lots of significant side effects. So the first generation of haloperidol, flufenazine, chlorpromazine, and loxapine all are the focus ones, or from the focus group of your ATI. The reason I pulled them out to show you here is to demonstrate that they have high, medium, and low levels of anticholinergic effects on the body. So your first generation drugs, your second generation drugs, even Abilify, are all designed to work on the dopamine pathways. And as I said before, there are 4 pathways. So each of these drugs have a nuance to them that makes them specific to a different pathway, or maybe more effective for one pathway versus another. In that process of working on the dopamine receptors, some of these drugs also impact the acetylcholine receptors as an unintended effect, because their receptor sites are similar. So if, for example, haloperidol has a high level of anticholinergic impact, so that means that they have significant anticholinergics, but unlike chlorpromazine, which has a low incident of anticholinergic effect, you're going to have a different level of side effect with that. And we're going to talk in just a few minutes about the anticholinergic crisis and what that looks like, and how the impact of acetylcholine and dopamine, that balance, how that impacts another side effect of these first generation antipsychotics, which is the extrapyramidal side effects. And that's going to be on a later slide, so we'll know that. So for your perspective, I want you to know what drugs land in the first generation, understand that they were early in innovations to address positive symptoms of psychiatric conditions, specifically hallucinations and delusions. The second generation kind of got its rough-edged, polished off. They began to realize that there were so many negative side effects to the first generation of drugs that we needed to find something that had less extrapyramidal risk factors, and really find a way to address the negative symptoms along with the positive symptoms. So the second generation aspired to do that. Now, they do it at varying levels of efficacy. So the intent with second generation was that they would do positive as well as negative, and then do so with less side effects. The second generation of medications had less onset of extrapyramidal side effects, but then we found that we had a new side effect, which was the neuroleptic malignant syndrome. To note, risperidone and clozapine and olanzapine are all those examples that your ATI book uses. There are a few more in there, but these are the ones I pulled out for you. Want you to remember just a few slides ago, I mentioned clozapine, actually, I think it was a slide before this, that is in the second generation of antipsychotics, but it is not recommended as a first-line use within that group, primarily because it has a significant side effect of lowering white blood cell count and causing agranulocytosis, which can be a fatal side effect of folks that have a clozapine regimen. If you have a patient that has been prescribed clozapine, they may have a really good clinical impact from this drug that may be really effective, but these are folks that have to have their white blood cell count watched very, very closely. So if you've got a mental health client that's not in a good support system and is not likely to be really compliant with aftercare and close supervision of blood levels, that's not a good drug to use because they really need to be closely monitored for white blood cell count. It's common enough. I want to say it's like 7 or 8% of folks that have clozapine will get agranulocytosis, and then when it happens, it's really hard to fix. So I want you to kind of tuck that way in the drugs that are different within the second generation category. And lastly, we're going to talk about the aripiprazole. I don't know why they can't make these sound so much easier to pronounce. Abilify is how I learned it. It is a more recent innovation. It's a more recent drug that's come out on the market. The significant concern with Abilify is weight gain. Again, Abilify is used across for its benefits of positive and negative symptoms, but it's also crossed over into our bipolar world, specifically for folks who really have mania or hypomania with a little bit of psychotic features. It works really well with folks that are in that bipolar spectrum as well. So we're seeing more of it on the market, but along with it, we're seeing more weight gain, and that places the client, predisposes them to diabetes type 2. So I want you to be able to identify the medications that your ATI books, and these are examples, and be able to figure out, is this a first generation, a second generation, and where does it fit on the side effect spectrum. So as a breakdown of just understanding these first, second, and third generations, your first generation were specifically for psychotic disorders. We talked about it being dopamine, to be having D1 and D2 are dopamine receptors that have, the first generation has the high affinity for acetylcholine receptors. So that's, if you remember, I was just speaking about those side effects of acetylcholine that are very common in this first generation of drugs. They were meant for positive symptoms, and this group of medications has a higher risk for extrapyramidal side effects, which we'll talk about in a few moments. It also has a higher prevalence of non-compliance, and the non-compliance is very often due to the risky side effects and how it makes people feel. So they were highly effective for positive symptoms, and then we had the issue of the side effects and then the non-compliance. And keep in mind, the side effects for these first generation medications were about the dopamine pathways and how it was impacting the dopamine levels, but also the incidental impact of the acetylcholine receptors. So you had two different receptors that were being impacted by one drug, and the side effects were pretty significant. And we'll talk about those in just a minute. When we think about the second generation drugs, the original intent was that the second generation would hang on to the benefit of addressing positive symptoms, but then it would also begin to treat the negative symptoms, the anergia, the anhedonia, the analogy, all of the things that were taken away from these psychotic patients with schizophrenia. The hope was that it would brighten their mood, give them more energy, decrease the speech issues that they were having. There has been a marginal improvement with second generation antipsychotics in addressing the negative symptoms. They're still doing research. They're still working on ways to continue to improve these drugs, but they are only marginally better than the first generation as far as addressing negative symptoms. What they did do was begin to decrease the risk for extrapyramidal side effects. But then, as I said a few moments ago, we had an increased risk for neuroleptic malignant syndrome. And in just a minute, I'm going to talk about both of those groupings of side effects, so you're able to put them in buckets. The third generation, the Abilify was very much part of the second generation. The slight improvements was there was a little bit less of the anticholinergic effect, but the other thing to be mindful of is significant weight gain that was noticed with the Abilify classification. Keep in mind this receptors, the 5-HT2A/D2. I want to make sure that you recognize that 5-HT2A, again, I'm not sure why they can't make these easier to remember. The 5-HT2A is a serotonin receptor. So this second generation medication had an impact on a serotonin receptor, which is very specific in this case, which is the HT2A, as well as a dopamine receptor. So the second generation medications are more often used in a schizoaffective disorder, which has the schizophrenia component, as well as the affective, which is the mood component. And I'll talk about that in your third video. So keep in mind that the second generation had some really good improvements. It crosses over into the use for positive and negative symptoms, can be used to address some of the symptoms associated with schizoaffective disorder, but we do have to watch clients that are taking this for neuroleptic malignant syndrome. Extrapyramidal side effects, Parkinsonism, acute dystonic reaction, akathisia, and then tardive dyskinesia. I want you to be thinking about what these look like. So Parkinsonian symptoms are also known as dyskinesia. Dyskinesia is the broader, more vague term of the muscle and motor movements that happen when someone is having an extrapyramidal side effect. Parkinsonian is more specific, and it specifically is talking about the slowing of muscle movements, rigidity, a shuffled gait, drooling, and tremors. Tremors tend to be one of the hallmark signs of extrapyramidal side effects, and you'll often see them in the hands because they're the most visible and also the body part that requires the most dexterity. And that's an early symptom when you begin to see hand tremors from the side effects of a first generation antipsychotic medication. The dystonia, the acute dystonic reaction, the dystonia that they're talking about are acute spasms, and they're most often seen in the tongue and the neck. And as you can see in these pictures, this is a picture of someone who had chronic mental illness and had not been treated properly for her extrapyramidal side effects. And you can see how her tongue protrudes and rolls in different places in her mouth, and her neck in the top left-hand corner, where her head is tilted back at a weird angle. That neck spasm is extremely painful, and if it's not treated, can become permanent. And when we don't treat the early symptoms of extrapyramidal side effects, what we have is the long-term side effect of tardive dyskinesia. So the tardive dyskinesia has the same Parkinsonian, dystonic, and akathisia fine and gross motor movements, those impairments, but what has happened is they've not been treated. And this was really common in the 60s, 70s, and 80s when we were using those first generation antipsychotic medications. We did not know how to properly treat the side effects and begin to decrease them. We know now that the use of benzotropine or Benadryl, Cogentin or Benadryl, Artane is another one that we use to treat extrapyramidal side effects when we first see them in the clinical course of the treatment, that we can prevent tardive dyskinesia. If someone has developed tardive dyskinesia from chronic use of antipsychotic medications that have not had their extrapyramidal side effects treat it properly, you can't undo it. So if you see someone like this woman here, it is not something that they can do anything about. They may use some muscle relaxants. They might try to do some physical therapy. Certainly, the hope was that they would change their medication regime. But the end result is it is what it is. So we want to be really attentive to looking for those early signs of extrapyramidal side effects and do oral dosing of benzotropine or cogentin or Benadryl, and do those early on. And sometimes they are ordered together. So they may have an antipsychotic along with one of the other treatment medications like the benzotropines or cogentin or Benadryl or Artane. They'll go together to make sure they don't have these side effects. One of the challenges with the anticholinergic meds is that they make them sleepy. So kind of trying to find that balance can be pretty challenging. So I do want you to be aware of the Parkinsonian symptoms, understanding that in that grouping that very much mimics someone who has had a Parkinsonian episode. It is not Parkinson disease, but it can mimic it. So they do have a significant change in their muscle movements. They have lots of rigidity. Their gait is abnormal. The big one that you'll see with this that you want to watch for is tremors. We normally see that. The dystonic reaction, remember, it's the spasm of the tongue and the face and often the neck. And then the akathisia, which is pacing and agitation, which looks like severe restlessness. All of those three not being treated well and early on can result in chronic tardive dyskinesia that's really resistant to any kind of treatment. You are more likely to see these with first generation antipsychotics. Every once in a while, you'll see it with a second generation, but it is not nearly as common. So when you think about the first thing to look for, if you've got a patient who's on haloperidol and they're having a tremor and they're having abnormal neck movements, their gait is shuffled, you're going to be really thinking about, okay, I need to go in and I need to assess this person for extrapyramidal side effects. And if you remember a few slides back in part 1, I gave you the DISC and the AIMS surveys, those scales. Those are the tools that are used to assess someone who has the extrapyramidal side effects and be able to develop to identify the severity of those side effects. All right, let's talk about neuroleptic malignant syndrome. So if we think about neuroleptic malignant syndrome, it is almost always going to occur with a second generation antipsychotic medication. This side effect is going to potentially be life-threatening. It looks like severe muscle rigidity. They have an elevated body temperature that once the body temperature starts to elevate, it begins to elevate quickly. It's one of those kind of snowballing effects that once you start seeing the symptoms, you need to address it very, very quickly. So you've got muscle rigidity. They will describe the muscle rigidity as a lead pipe rigidity, and it is truly a very rigid, tight muscle grouping. It is uncomfortable and painful. Think about a Charlie horse in your muscles. The person is very uncomfortable. They will also begin to have a low-grade fever that quickly climbs into life-threatening degrees. Early symptoms, you're looking for in early treatment with a second-generation antipsychotic. You're watching their vital signs closely, especially looking for any spike in temperature. And the first thing you're going to do is, if you begin to see the symptoms, is you're going to treat the symptoms and then you're going to withhold the antipsychotic medication. So if you have a client who you see who's having symptoms, you want to make sure that you're addressing the symptoms directly. And the dopamine agonist, which is the bromocriptine, is the first line of drug, and bromocriptine is used to help with the bromocriptine is designed to help decrease the amount of dopamine that is available, and then you're going to use a muscle relaxant like danotroline. Both of these two are first-line treatments for your your first assessment of the neuroleptic malignant syndrome. So if you see someone that is on a second generation antipsychotic, they begin to have muscle rigidity that begins to be moderate to severe, they begin to have a fever, you want to dose them with a now dose of the bromocriptine, and then you're going to, of course, you're not going to give the medication on the next dose, and you're going to let the physician know. But the first thing to do is make sure you're treating it, and you want to treat it quickly. White blood cell counts, again, this is on your list just to remind you that really lines up with, it's going to be a baseline for anybody in a second generation antipsychotic, because they're all have the risk of impacting white blood cell count. Clozapine is the big one that you're looking for white blood cell counts. So this medication is, the second generation antipsychotics are great drugs, but you want to be aware that we're transitioning away from that high risk of extrapyramidal syndromes to more of the risk for neuroleptic malignant syndromes. Neuroleptic malignant syndromes is very rarely seen from first generation drug antipsychotics. It's just not seen as often. Every once in a while, the wrong combination of medications can mimic this and can the person may be screened for this, but it's not nearly as common as you would see this with second and third generation antipsychotics. The Abilify, that one single third generation, is less likely to have the neuroleptic malignant syndrome, but because it still has the main chemical structure as the second generation, there's some crossover, but not as much. You really want to focus on those second generations when you're looking for this. And again, you're looking for that elevated fever, that lead pipe type of muscle rigidity, and knowing that that the treatment they need to be treated quickly for the symptoms, that you're not going to give any more medications, and you're going to follow them pretty closely. So we talked about the first generation of antipsychotic medications and their cholinergic effects. So one of the risks when you have someone who has the cholinergic crisis, which means that their body is flooding with the anticholinergic effect, you can have too much of the acetylcholine receptors being stimulated, because you're also stimulating the dopamine receptors. The other thing that could happen is that being treated with cogentin or Artine, those two anticholinergic medications that you're given along with first generation antipsychotics, to prevent the extrapyramidal effect, the combination can accidentally cause an anticholinergic crisis. So if you have a medication that is highly cholinergic and it's designed to hit the dopamine pathways, it's incidentally hitting the anticholinergic receptors as well, and then you're giving them cogentin to help balance out the side effects from the EPS. You're overwhelming the acetylcholine receptors. So that is often what happens when you have the anticholinergic crisis. It's that combination of the antipsychotics, anticholinergic effects that's incidental, and the combination of a anticholinergic drug to prevent the side effects. So it's this response that your body has. So when we think about the anticholinergic crisis, this is something that you've probably seen from your med-surg courses. We look at them, that's often said that they're hot as a hare, blind as a bat, mad as a hatter, and dry as a bone. So hot as a hare is hypothermia. Blind as a bat is blurred vision. Mad as a hatter is confusion. Dry as a bone is dry mouth. And then red as a beet, which is another one that's added later, is flushing. All of those are concerns that they're having a anticholinergic crisis. Additionally, from the hypothermia, blurred vision, confusion, dry mouth, and the flushing, are that they will have dilated but non-reactive pupils. So their pupils will be dilated, but when you do a neuroassessment, they're not reacting. And they can also have ataxia, which is the lack of muscle coordination that is commonly seen with this. So when you see a client who's experiencing this, you need to kind of figure out, you need to go back in and look at what medications that they're looking at. You're going to stop all those medications. You're not going to give any second doses. And then you're going to treat them with the physostigmine, which is a medication that is designed to increase the uptake of acetylcholine. It's going to decrease all of those receptor sites from reacting to the anticholinergic medications and help your body use them more appropriately and get rid of them. So, the first thing to do is first assess, make sure that you're looking at the right things with medications. And then you're going to give them any standing dose that you have of the physostigmine. And then you're going to make sure you don't give additional doses. So do what you can in the immediate stance to address the symptoms, and then discontinue doses. And then the physicians will follow up and determine how they want to move forward. The other thing that's recommended from treatment is gastric lavage and charcoaling. And this is specifically if there was an intentional overdose. Let's say someone has schizoaffective disorder, so you have a mood component along with your psychosis, and part of their mood component was a significant, a major depression episode. Then they may have suicidal ideations. There may be some suicide behavior, and if they intentionally took all those medications, then you're going to do a gastric lavage and try to get as much out of the system as possible. So you really need a good history. You need to know exactly what medications they've been taking to determine, what that first course of care is. We think about those first few slides covered the biologic domain of nursing management. As you can see, the puppies have come back in from their walking. My hope is that they do not become too disruptive. So we're going to shift and talk about the psychological domain and what the psychological assessment should look like. It is important for you to look at these aspects of where they are from a psychological domain. I want to call your attention to just a few things. First, I want you to just remind you about mood and affect. Mood is what the patient says it is. Affect is what you observe about their actual mood. And you're always looking for congruence. You also, when you're looking at mood, you're looking for lability or affective lability. You are looking for I need to back up. When you are looking at mood and affect, specific to affect, you're looking for affective lability. So as you're watching the patient behave and interact, you're looking for abrupt and unprovoked changes in their affect. Do their facial appearances change? Are they smiling one moment, crying another? Do they look fearful in one moment, but then they're happy in another? That could be a symptom of responding to external stimuli. You're also looking for ambivalence. You're looking for an expression of two opposing feelings leading to its inaction. So if they are looking at you and they are, they're very flat, they're not smiling, there's limited eye shifting, and you ask them how they feel and they say, I feel great. It's the best I've ever felt. That incongruence is a cause for concern. You want to try to figure out what's causing that incongruence and assess whether it could be ambivalence because they are experiencing some kind of psychotic feature. And then apathy, which is little emotion at all. So again, when you're looking at that affect, you're looking for, what are the things I'm seeing? Are they labile? Are they ambivalent? Are they apathetic? And what are they saying? What are they telling me about their mood? And you're looking for congruence. I also want to point out insight and judgment. Insight is the recognition that their experiences that are disturbing to them, that they are aware that it's part of a mental illness. And judgment is the ability to take action on a situation or a concern. Insight and judgment can be really limited with folks who have schizophrenia. So I want you to be aware that one of the focuses in treatment is to heighten insight and help them improve their judgment. So the more aware they are that they're that the things that they're experiencing, the auditory visual hallucinations, the delusions, the false beliefs, the more insight they have that those things are part of a mental health disease, the more likely they are to be compliant with medication. So that improves their insight. And then when we look at judgment, we want to help them make decisions about medication compliance and using resources and creating a safety support network so that they have support when they are struggling during a relapse. So I just want to highlight those key concepts from the psychological assessment for you here. The nursing diagnoses from a psychological domain, I just want to remind you that disturbed thought process is about delusions. When you think about disturbed sensory perception, that is about a person having hallucinations. So if you have a client who is hearing someone talk to them, then their nursing diagnosis is going to be a disturbed sensory perception. If they believe that the FBI is tapping their phone and trying to get information about them so they can send them to jail, that's a disturbed thought process, and the disturbed thought process would be their primary nursing diagnosis. So I want to point those out. The others are also good diagnoses to be aware of for these clients. From a psychological intervention standpoint, this goes back to something I said earlier, is developing a nurse-patient relationship. Compliance for treatment regimes and following through and aftercare, taking their medications, really relies on a good trusting relationship with the care provider. And you want to be as trustworthy as possible and as helpful and supportive to your client as possible. The other thing that you want to do with is you want to make sure that in that trusting relationship that you're helping the client deal with the feelings related to their hallucinations or the delusions. You do not want to challenge them, tell them that what they're experiencing isn't real. You want to be able to share with them that you know to them that it's real. You don't want to say, oh yeah, I hear that guy talking to, or, that's probably just your dead grandmother giving you, information. You don't want to feed into the delusion, but you don't want to say, that's not real. That's not happening. What you do want to be able to do is say, I realize that, that you hearing that voice is probably pretty scary. Talk to me about how you feel about when this is happening and what I can do to make you feel better about this. When we look at the social domain, the primary focus when you're looking at the social assessment, the nursing diagnosis and intervention is really addressing social isolation. You want to look and find out what their support structure is, who their primary care provider, who their primary support system is. Find out how engaged they've been in the world around them, how isolating they are, and make sure that you're involving family in or the caregivers or support system as much as possible in planning aftercare and interventions and treatment for how the patient, once they're discharged or they're back in the community, how they're going to manage. We think about a nursing diagnosis, really are looking at impaired social interaction. And this, because social skills can be pretty challenging, a focus area to improve socialization is encouraging them to participate in group therapy. And group therapy is going to be pretty straightforward groups. They're not going to be these deep, long, cognitive behavioral therapy groups that really require lots of attention span and lots of introspection. The group therapy sessions are going to be more functional. It's going to be more straightforward information, more casual information, where you're just trying to increase their socialization, increase engagement. It's a key component of decreasing their isolation, and that isolation is one of the things that lead them to feeling hopeless and becoming more erratic in their behavior. So the more dialed in you can support them in being, the less isolated they're going to be, and the more likely they're going to stay engaged and have the support they need to stay in recovery. When we think about evaluation and treatment outcomes, we really are trying to be recovery focused. This slide tells you that successful treatment and management with significant improvement or recovery, that's our goal. We want to help them live with this chronic mental health disorder, and that can be super challenging. a key to their support, a key to their recovery is good case management, a good support system, and the involvement of people that are supportive of this person's life. And that is really stressful on families. So we want to make sure that we're offering family therapy, that we're offering the external support system like counseling when needed or support groups. There's NAMI offers support groups for folks that are living with chronic mental illness and loving someone. So we want to make sure that we've helped them get dialed in to what that recovery network looks like, not just for the patient, but also for the family system. This last slide is, it's actually a video link that I'm going to leave up for you. I'll put it as a YouTube video. Lisa Halpern is a great example of what being, having schizophrenia and having those first psychotic breaks, what happens when you are loved well, what happens when your social network supports you well, what happens when you know to ask the right questions and you know things aren't the way they're supposed to be. So I'm going to add her video in so you can take a look at her. It's a pretty brief story, but I think it gives us hope. It lets us know that people can live with chronic mental illness, specifically schizophrenia, with a good social support structure, with a good medication management regime and med compliance, that these people can live in recovery. They may never be back to their baseline, but their life can be stable and they can still be productive and still have hope in their future. So I think Lisa's story does a great job of that.